Next presentation is going to be Chad Hughes going to talk to us about aortic type A dissection with malperfusion. Chad?
Thanks, Joe.
Need that.
Good afternoon, everybody. Also like to thank Morale, David Adams, and Tyrone, obviously, for all he's taught all of us. He's a legend, and we should just be thankful for how much he's done for our specialty. These are my disclosures. So I thought I'd give a little bit of background because I do think this topic's a little bit controversial. This is a recent STS database paper. A number of people in the room are co-authors, but it looked at type A's in the STS database from like 2017 to 2020. There was like 10,000 patients, and the incidence of malperfusion in patients undergoing repair, type A repair, is about 28%, and the mortality is about 27%, which is 10% higher than if you didn't have malperfusion. Extremity is most common, but coronary is most lethal, along with visceral and spinal. The cases I'm going to present are going to be a couple visceral cases, because I think those are kind of the most challenging decision-making wise. But this is a controversy. This is an area of aortic surgery where I think we need better data. We have a lot of areas like that, but this is certainly one of them. You know, whether patients with malperfusion get immediate repair, or do they get so-called complication-specific approach. I think immediate surgical repair is arguably the best approach for all patients, whether or not they have malperfusion, but there's not really much data comparing the two approaches. I don't know if any of you know Mike Deeb. He's a great guy, and he tells a funny story when he presented this paper at the STS in 1997. He says he was booed off the stage. This was when they presented their complication-specific approach, where they would do distal fenestration to relieve malperfusion and then let the patient recover and then fix the dissection delayed. But Dr. Greep discussed it. I don't know if Craig Miller's here, but he discussed it. They both called it iconoclastic and didn't seem to agree, but it has caught on. And this is their data on specifically for visceral malperfusion type A, where they recommend this complication-specific approach. But we do have to recognize that there is a risk of rupture with that. It was 13% in their series, although in the second decade they had no ruptures. And a quarter of the patients still died from multi-organ failure despite restoring the flow. So we use this approach, I would say, pretty highly selectively at our institution. Most people get immediate repair, which this is a UPMC. I think this is a good paper from UPMC because they have the opposite policy. Everyone gets immediate surgery, and in this series, they basically were comparing their malperfusion patients to their non-malperfusion, and about half the malperfusion patients get a total arch there. But interestingly, the outcomes for the patients that had malperfusion versus not was basically the same for renal, visceral, and iliofemoral. Now, if you had coronary malperfusion or you had a stroke, your survival was worse, but their overall mortality was better than has been reported by the Michigan group. So it's controversial. But we have a number of options. I mean, if the patient has a big primary tear in the ascending aorta, you don't have to do a total arch in every single patient that has malperfusion. If it's pretty clear that the source is the ascending aorta, we could do a hemiarch repair with zone 0. Otherwise, if the tear is beyond the innominate artery or beyond zone 0, you're probably looking at some sort of frozen elephant trunk procedure, whether it's conventional TEVAR and sewing a graft to it, whether it's Thoraflex, whether it's Eric's Be Safer technique, and now we have the MDS stent, which was designed for malperfusion and can be done in conjunction with the hemiarch. I'm not really going to go into that. I'm going to talk the case I'm presenting will be an FET case and then a complication-specific approach case. So this was a patient who has what would be called a B0 dissection in the SVS-STS classification. He's got a primary arch tear, retrograde intramural hematoma, and distal dissection. And you'll see this true lumen as you come down. There's the tear. You can see the animation here. Is this true lumen as we get down to the visceral segment gets totally smashed. I mean, it is like barely open. But despite that, the guy didn't really have any GI symptoms, interestingly. But we felt that was something that we should fix. So the video is just showing us removing all the IMH with the aortic clamp. But I do all these total arch cases with right axillary. I sew an 8mm Dacron side graft. The bottom left picture just showing how the incision extends up along usually the left border of the sternocleidomastoid, so you can really get exposure out onto the arch and get all the arch vessels. We use low, moderate hypothermia, systemic hypothermia. That's measured by nasopharyngeal, not bladder, so it's actually pretty quick to cool and warm. And then I use Plegisol. I don't usually use Del Nido in these kind of cases, and typically in a dissection it's going to be retrograde and then direct osteal. I use myocardial septal temperature probe. I learned that from when I was at Penn, and I think that's a really good way to make sure you're protecting the heart. But you know, I don't have any problem clamping the aorta. It's coming out anyway. And then while we're cooling, we'll do our proximal work, resuspend the valve. And then when we get to our target temperature, then we're going to stop whatever we're doing down there and go up and work on the arch. And I'm usually doing a zone 2 arch in these with a unilateral ACP. All 3 head vessels will be clamped. And the way that you can do that is basically we'll staple the left subclavian with a TA30 stapler and then divide it. And that way it's a nice hemostatic way and lets you stay proximal left subclavian, or you don't have to deal with recurrent nerve, phrenic, increased risk of phrenic injury out there. But this is just the video going to show where we divide the arch. I guess there's a little bit more IMH we took out. You obviously want to get all that out of there. And then, you know, here we're resecting the arch just distal to the left common carotid in zone 2, which is, again, that's kind of my go-to for these total arch distal anastomosis locations. So next, this is just showing, in this case, we did kind of a, you know, conventional FET, didn't use Thoraflex. Actually, this is a Gorsi tag just deployed upside down, which to decide on the size, I usually just kind of size it to like no oversizing to whatever the arch would be or the descending. But I like this approach for these type A's because when you sew it, and Eric looks like he has somewhat of a similar technique, but I don't use 2 suture lines, but you'll see next, I just sew the graft and incorporate the stent graft in the aortic wall, and that Gore-Tex makes it, it's very hemostatic. I mean, it's a nice technique. I really like it. And so, you know, the grafts that we use, the one in the video is one where all the branches come off a single trunk. We also use the one in the bottom left, which has multiple branches. I don't really think it matters that much, but they all have this perfusion side branch, and so this arch is being sewn with just like a 4-O-proline and getting all the layers. But once we finish this arch, then we will use the perfusion side graft to go back onto the lower body. So the lower body circ rest time is very short. It's like not really much different than doing a hemi-arch. And so you avoid some of the issues with paraplegia, renal dysfunction, et cetera. And then once we are back onto the lower body, then we'll move on to doing the arch vessels next. But we do the arch first approach. And so here the video is going to pick up, we've already done the left subclavian. So really once you get the left subclavian reimplanted, because you're perfusing from 2 spots, you have a Y in your arterial line, you basically can get the left brain. So you're going a nominate to the right brain, and then through the left vert, you're going to get the left brain. And then you'll put your carotid on, and you know, as you can see, the carotid is often small, and so a lot of times you have to spatulate it maybe to make it match the graft. But I'll do the subclavian and then the carotid, and then I will not do the innominate right away. I'll go back and finish what I have to do with my proximal, sew the grafts together, take the clamp off, and then do the innominate with the clamp off and the heart beating, so it shortens your cross clamp time, and that seems to work well. And then in this case, you know, even though it's radiographic malperfusion, you do not want to leave somebody with that visceral segment like that small. That's not a stable situation. So 2 days later, we took him back. And usually we'll just do covered stents down to the celiac, so we extend in with a C-tag, and then we'll assess everything by IVUS. And by IVUS, he was still compressed distally, so we just did these, the Zenith, the stents that Joe Caselli should have taken out in this video, the ZDES bare metals down to the bifurcation to open everything up. And I don't do those routinely. Like, I only do it for malperfusion. I don't think it improves. I don't think the data really supports it improving remodeling. I think it's just it's a malperfusion situation. Now here's a different case. This is a guy, middle-aged guy, who had a prior double valve at another institution 7 miles down the road that wears the wrong color of blue, and he did fine. But then he came into the ED one day and had some abdominal pain and got sent out, and came back the next day because he was passing blood in his stool and his abdominal pain was worse. And at that point, they got a CAT scan, and you'll notice on this CAT scan that he has a type A dissection with a big primary tear in his ascending aorta. And look at the true lumen; it's right there. It just gets totally smashed. And I should have pointed out, but he had air in his liver, portal venous gas, pneumatosis of his bowel, peritonitis on exam. So that goes laparotomy first. Fortunately, the whole bowel wasn't dead. but they took out his terminal ileum, did a right hemicolectomy, and interestingly, they hooked him back together. Had poor pulses in his viscera, so we did a complication-specific approach in him with, we don't usually do fenestration, we'll do stent grafts. And we actually first described this in 2010 because at that point the complication-specific approach was just fenestrations, and then we did this case, it was a different kind of thing, but he presented ischemic liver, ischemic bowel, and this was before we had the Zenith stent, so there's a palmaz in his visceral segment. But as we point out there, this is really just select for patients that would with established visceral ischemia, not just radiographic. But this is this guy's initial angio. When we take him, that's called the floating viscera sign. When you see that celiac and that SMA light up and there's nothing around them, that's because the true lumen is like 100% smashed there. So as you saw in the CT, the true lumen was pretty good until right just proximal to the visceral segment. So we put just a short C tag in there and shot another angio, and just that one stent alone opened everything up. We'll IVUS it too and make sure it's good, but we did not really need to extend in this particular case. This is what the IVUS, this is actually a different patient, but this is what it looks like. You can see that visceral segment is completely smashed there. That's the left renal vein that you're seeing crossing in the visceral vessels coming off. And then after we stent them, this is coming. You can see that was in the stent, and the IVUS has come out of the stent. Now you can see how big that visceral segment is with resolution of the malperfusion syndrome. So this guy leaked, he was septic, he was sick for a long time, multiple drains. So it took him a while to get to his proximal repair, but he did get a scan in between. You can see that one stent, how much it opened everything up. But eventually he did undergo a proximal repair, and in this case was, I don't know, several years ago. He's still doing fine. But I do think, and Eric mentioned this a little bit, I do think a lot of these cases are going to go endovascular in the future. In my experience, I think a lot of the type A's with malperfusion, it's actually an arch or proximal descending tear. It's not an ascending tear. So those patients probably are going to be fairly amenable to endovascular. And as he mentioned, the Gore Rise 3 trial will be starting with an ascending device. So I do think some of these super sick ones are going to probably go endo in the future. So again, thank you for inviting me. Congratulations, Dr. David, and look forward to the discussion.